Welcome everyone to the Technical Assistance Network for Children's Behavioral Health, Cultural and Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a monthly call or webinar with topics focusing on culture, health equity, and disparities in children's behavioral health. Topics are generated by you, individuals working in or being served by behavioral health organizations and partnering with system of care states and communities. The TA Network, as it is known, is the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration, SAMHSA. My name is Kathy Lazier. I'm a faculty member at the University of South Florida and the co-director of the Cultural Linguistic Competence Hub of the TA Network. For today's topic, implementing the National Standards for Culturally and Linguistically Appropriate Services, better known as CLAS, I am joined by Selena Webster-Bass, the Executive Director of the Voices Institute in Jacksonville, Florida. Selena's background is in public health, minority health, and health equity. In addition to a role as a national consultant with the TA Network, Selena is also the Cultural and Linguistic Competence Educator for the Jacksonville System of Care Initiative. Catalina Booth had a family emergency, so she will be unable to be on the call today, but we appreciate the input that she had in this presentation. This presentation is being recorded. Your lines will be muted right now to help eliminate the background noise, so feel free to use the chat box to type in any questions or comments during the presentation. Following the presentation, we'll open the line for further questions and for discussion. The TA Network will be sending a link to everyone who registered where you can access the recording and the slides. And we hope that you join us next month on September 1st at 1 o'clock for our next peer learning exchange call, which will be focused on faith-based organizations in behavioral health. So look for details in the TA telegram. The purpose of, change the slide. The purpose of this presentation is to provide you with information about implementing the CLAS standards in your efforts to meet the needs of persons of diverse cultural, racial, religious, linguistic backgrounds, disability status, socioeconomic status, gender identity, and sexual orientation. This presentation will include a brief history and overview of CLAS standards. Many of you are coming from this, with a lot of knowledge around CLAS, and some of you are relatively new to this idea of using CLAS standards. And we're also going to be looking at an example from Broward County, Florida, and I want to thank our colleagues at Broward County for sharing their work so that others can learn from the experience that they had and how they have begun to use the CLAS standards as a foundation for program development and evaluation. In order to reduce disparities in care, we must first understand where the disparities exist, the scope of the disparities and the root cause of these disparities. This is an ongoing, continuous process, and unless it's measured, disparities in care can go unnoticed, even as organizations seek to improve care. So the awareness of what the data shows can have an impact on program planning, development, and improvement. Your data will need to be stratified by race, ethnicity, language, gender identity, sexual orientation, and in other ways that can help to identify where the disparities exist and to take action. So remember, what gets measured and understood in terms of the root cause is what you're going to be able to manage. So we know that the behavioral health equities exist, and we can present you with a lot of the national research that consistently shows that people from different backgrounds, and geographic locations, gender identity, race, have unequal access to care, and that there's a disproportionate utilization rates. So they're either underrepresented in certain services or they're overrepresented in certain services. There have also been persistent disparities in health outcomes and in healthcare itself. That is that certain groups of people have less access to behavioral health services and poor outcomes even when they are in service. And we have some examples here. So for example, in a 2012 study, education was associated with greater service use for whites, but less service use for African Americans. Also, blacks who used services in the past were significantly less likely to be current users. A national survey on drug use and health back in 2003 to 2011 data indicates that Hispanics aged 12 or older were more likely than non-Hispanics to have needed substance use treatment in the past year. 2011 report indicates that persons aged 12 years or older American Indians, Alaska Natives were more likely than persons from other racial groups to have needed treatment for alcohol use. Similarly, American Indian or Alaska Natives were more likely than their persons from other racial ethnic groups to have needed treatment for illicit drug use as well. So we know that these persistent disparities continue to exist, and we can include more in terms of the Asian adolescents for the United States having higher rate of alcohol use in the past month. Racial and ethnic minorities using deep end services rather than community-based services. And what's interesting that Selena had pointed out in the previous presentation was, talking about that ethnic minority persons are especially likely to exhibit crisis-oriented patterns of mental health care, which contribute to the lower quality of mental health care sometimes that are provided to our ethnic minority groups. Mental health care, for example, for African Americans occurs relatively frequently in emergency rooms in psychiatric hospitals. And so these settings and patterns of treatment sometimes undermine the delivery of high-quality mental health care. And we know that health disparities are associated with multiple factors. Providers understanding cultural health beliefs, stigma, and their impact on behavioral health outcomes is critical. The Institute of Medicine, the Agency for Healthcare Research and Quality, the Centers for Disease Control and Prevention, Health Resources and Services Administration, a number of foundations like the Robert Wood Johnson Foundation or the Center for Healthcare Strategies. These are just a few of the organizations that contribute to the research based on disparities and disproportionalities. So what we'd like to share with you is this is an example. And again, I want to thank Broward County for sharing this data with us. This is an example of getting to know your demographics, getting to know your populations, and to begin looking at disparities. So if you take a look at a few of the demographics of Broward County, which contributes to its rich history and complexity, and we're going to talk a little bit about where a lot of these are coming from. But, Broward County is a county that's located in the southeastern coastline in the state of Florida. It's home to almost 1.8 million people. It has the sixth largest public school district, 200 countries speaking 130 languages are represented by students in Broward County. So you can see that it's a very diverse area in terms of race, ethnicity, languages, and socioeconomic status. So some of this information that you can get from census reports, and then now also you have to look even deeper in terms of the disparities and disproportionalities that exist in your community. So for Broward County's behavioral health disparity impact statement, what's very important is that they use multiple sources of data. Broward Public Schools looked at emotionally, behaviorally disabled student enrollment and dropout rates. They used community surveys, and the school collected data about their LGBTQI student population. I'm not going to go through all the data here, but I just want to get a sense of where they were getting some of their data around disparities. They looked at transition age youth, and Broward Behavioral Health Coalition, which is the largest funder of behavioral health services in the county, had data on their transition age population, and Juvenile Justice had data to share, and they identified disparities. There was data from Broward Behavioral Health Coalition, youth that were diverted to treatment programs rather than commitment programs, and it revealed that 61.5% were white and only 38.5% were black that were in diverted to treatment programs. And this is a key finding around health disparities on the forefront of system and clinical review, whereby their system of care aimed to reduce through cultural diversity impact reviews, and further evaluation of their current system processes. So you can see where they were collecting a lot of different data. So when we look back at the history of CLAS, or this history of why we're even looking at disparities and disproportionalities, there's been a history of and continues to be a national call to action to address disparities that are experienced by diverse children and their families and the organizations that serve them. And this particular timeline just highlights some of these actions. Most importantly, I think, when you look at these is that the CLAS standards are strongly linked, and they're inseparable bond to the historic 1964 Title VI of the Civil Rights Act law, which prohibits discrimination on the basis of race, color, and national origin in programs and activities that receive federal financial assistance. So they're very closely linked and kind of inseparable bonds. So you can see, throughout this timeline that there have been a number. The Section 504 of the Rehabilitation Act in 1973. In 1975, they enacted an All Handicapped Children's Act. There was an Assistive Technology Act, that recognized that assistive technology can improve the access and function of people with disabilities. So if you look, continue to look through this timeline, and if you Google any of these things, you'll see how this national call to action has kind of played out historically until we get to the enhanced class standards back in 2013. And actually Healthy People 2010 was recently updated, and it's Healthy People 2020. So there's a continuous look now and a continuous call to action around addressing disparities and disproportionalities in behavioral health. So in light of all the research, the current demographics, the ever-changing demographic landscape, it's a given that organizations serving children and families will want to and will need to, one, ensure that all have access to health services, that they will improve client health satisfaction, that they're going to increase staff confidence, become more viable for grants and contracts, and also reduce costs. There's also financial cost of racial and ethnic health disparities. Long existing inequities in health and healthcare have come at a steep cost, not only for minority communities, but also for our country as a whole. As cited in a report from the Agency for Healthcare Research and Quality, the burden of insufficient and inequitable care that's related to racial and ethnic health disparities has been estimated to top $1 trillion. The other thing is preparing to meet federal and state requirements. There's an increasing emphasis on cultural identity, which encompasses and exceeds race, ethnicity, or language. So we know that increasing cultural competence is going to be a benefit of implementing CLAS, which is why we have really found that utilizing CLAS as a foundation for some of the cultural linguistic competence planning and strategies that communities are using has been very helpful. The principles and activities of CLAS should be integrated throughout an organization and system of care and undertaken in partnership with the families, youth, and the communities being served. So in systems of care, this is one of the roles of your family organizations, like the Federation of Families, and your youth organizations, such as Youth Move. So CLAS standards need to be integrated into and implemented at all levels of a system of care, and they're written that way. Selena will be talking about that. They're implemented in policymaking, management, community and service, or frontline practice levels. The research and events that we hear about every day also tell us that racial, ethnic, and cultural disparities persist in all aspects of American society. Many of these disparities seem unmanageable, stubborn, with no easy solutions. They are part of a deep-seated social and economic conditions, and often persist because the design of systems that we put in place to solve problems may actually sometimes create a barrier or limit the ability to implement effective solutions. So for this reason, CLAS integration must be structured. That is, it has to be deliberate and not left to happenstance. So multiple strategies are going to be necessary to implement CLAS standards throughout a system of care. So what I want to do now is to turn it over to Selena Webster-Bass, who's going to provide some information about the CLAS standards and also to share a community's use of CLAS as a foundation for assessing their cultural linguistic competence. And I know that some folks in the project director from Broward County is also on, and so I want to just let them know that, yes, absolutely, contribute. And I think that we're opening up the lines at the end of Selena's presentation, so definitely look forward to hearing from you as well. Thank you. Selena?
Thank you, Kathy. As Kathy has mentioned, the blueprint for cultural and linguistic competency practice is the National Culturally and Linguistically Appropriate Services Standards. And these standards were originally published in 2000 and were republished in 2013 by the Department of Health and Human Services, Office of Minority Health. And these standards are really action-oriented. It's an action-oriented framework that provides recommendations for operationalizing cultural and linguistic competency by advancing health equity, improving quality of care for youth and families with behavioral health challenges. The 2013 enhanced standards, and there are 15 standards, were expanded to include the definition of culture. So the definition of culture was expanded, not just race and ethnicity, but also geographical location, sexual orientation, gender identity, socioeconomic status. So the definition was broadened with the new 15 standards in 2013. Also, the understanding of health was broadened as well to include social, spiritual, mental, and physical well-being. The National CLAS Standards aim to assist behavioral health agencies in considering the elements critical to delivering culturally and linguistically appropriate practices. The National CLAS Standards include three primary themes. The first set of themes are governance, leadership, and workforce development. Governance refers to the oversight that a behavioral health organization provides in terms of policies, structures, and processes. So for example, having a language access policy. When a family or youth enters the behavioral health system, are staff aware of services that should be provided to this family that may have limited English proficiency? Do they know what number to call? Do they know what that process entails? Leadership, which refers to the influence of key decision makers within an organization. Workforce development, the hiring, recruitment, and retention of diverse professionals, and also offering cultural and linguistic competency training for behavioral health professionals as well. The second set of themes are communication and language assistance. Language is a key component of culture. Individuals may speak the same language, but their styles of communication and nonverbal methods may be different. So it's important that behavioral health providers are educated about personal space, use of silence, gestures, eye contact, formal, informal register, and understanding that these things are culturally defined. It's also important for behavioral health providers to participate in cross-cultural communication training to facilitate effective communication. The Communication and Language Assistance Standards, Standards 5 through 8, increase health equity through a framework for understanding diverse populations. And these standards emphasize offering language assistance at no cost, facilitating timely access, informing individuals of language assistance services clearly, and ensuring competence of of interpreters, and promoting health literacy, and policies specific to forms, signage, and printed media. According to the 2013 U.S. Census Bureau American Community Survey, over 25 million people over the age of 5 are living in the U.S. with limited English proficiency. English proficiency refers to anyone above the age of 5 who reported speaking English less than very well, as classified by the U.S. Census Bureau. Over 60 million people in the U.S. speak a language other than English at home. In a 2011 study, it showed that compared to individuals who are English proficient in similar circumstances, individuals with limited English proficiency and behavioral health disorders were less likely to identify a need for behavioral health services. And they took longer in seeking healthcare services and used fewer services for behavioral health disorders. So interpretation and translation services are needed so that families can make informed healthcare decisions. And as Kathy mentioned, we have federal legislation, Title VI of the Civil Rights Act, which was later expanded with the Executive Order 13166 that states that people with limited English proficiency should have meaningful access to federally conducted programs and activities. The final theme is continuous quality improvement, and these standards 9 through 15, focus on the assessment of community demographics. Behavioral health organizations should know who they're serving. They should know educational status, all of those factors that are important in terms of healthcare decision-making. Analysis of behavioral health outcomes and demographic data to address inequities and inform strategies in reducing health disparities. All of the 15 standards are founded on the principal standard for all of the national CLAS standards. The principal standard creates a safe and welcoming environment at every point of contact that both fosters appreciation of the diversity of individuals and youth-guided and family-driven care. Culturally and linguistically competent care is effective, it's equitable, respectful, and understandable. Effective care and services are those that successfully restore an individual to his or her desired health status and help to protect his or her future health. Vital to the provision of effective health care and services, providers must accurately understand the issue or illness, determine the course of treatment or services for that individual, and negotiate the solution or treatment successfully with the individual. Equitable care and services must apply to all individuals and groups regardless of their cultural identity. The aim of equitable care and services is to reduce the burden of illness, injury, and disability and to improve the health and functioning of all people. Understandable care is clear exchange of information between those providing care and services and those receiving them. Individuals should be able to fully comprehend how to access care and services, what their treatment options are, and what they need to get to stay well. And finally, respectful care is the fostering of an environment in which individuals from diverse backgrounds feel comfortable discussing their needs with any member of the behavioral health organization staff. That means providing individuals with assurances that don't discriminate or create an environment that is intolerant. It means providing individuals with reasonable assistance to overcome language, cultural, physical, or communication barriers. Health professionals should understand and be aware of the role that culture, health beliefs, and practices play in the lives of the individuals that they're serving. For the next few slides, I'd like to provide some specific examples of how to implement the CLAS standards within behavioral health organizations across these various themes. So our first set of themes are governance, leadership, and workforce development. So the foundation of any organization is their core values. You know, the core values of an organization are really the heartbeat of the organization. They define what's important to the organization. So it's important that cultural and linguistic competency is infused within the mission statement, the vision statement, and the core values, and even the strategic plans of behavioral health organizations. Also, behavioral health leaders should identify cultural competency champions, and not just within leadership, but throughout the organization. So also at the direct service level and at the administrative levels as well. Any staff member that's coming in contact with families and youth should be involved in cultural competency. Under this particular category, we should also include written policies, processes, and structures. Cultural competency should not be an accident, but it should be written and clearly stated and communicated to staff throughout the organization. And finally, ensure that necessary resources are in place to sustain cultural and linguistic competency activities. So this means professional development, funding for linguistic services, having an actual CLC budget that outlines the value of cultural competency in reducing health disparities. The next set of themes are communication, language assistance, and health literacy. And here are some specific ways to implement these themes within behavioral health organizations. Ensuring mechanisms are in place to facilitate the exchange of information with individuals that do not speak English, or people that may be deaf or hard of hearing. Ensure staff is trained in language assistance services, policies, procedures, and Title VI of the Civil Rights Act of 1964. This is really important. Oftentimes information may be at the leadership level of the organization, but that information is not filtered down throughout the other levels of the organization. So it's important that training is a part of language assistance and communication as well. Identify processes such as I Speak cards so that individuals who have limited English proficiency are easily identified. Establish language assistant contracts for in-person interpreters, bilingual staff, and also telephonic, video, remote interpreting systems. Using qualified trained interpreters to facilitate communication, and of course, not using family members, and particularly not using children in providing interpretation. One, we cannot ensure accuracy, and also it's not considered good cultural competency practice. Ensure written materials are translated for people with limited English proficiency. And then, of course, we want to make sure that we're conveying information in an understandable way by adhering to health literacy principles, making sure that educational materials and forms are written at least 6th grade level, ensuring materials and signage are written at an appropriate grade level for low literacy populations, and also avoiding medical terminology and chunking information so that it's easy to understand for our youth and families. The third theme is engagement, continuous quality improvement, and accountability. And here are a few examples of ways to implement those themes within behavioral health organizations. So conducting community assessments and using that data to understand who's being served. Conducting organizational assessments and using that data to improve service delivery. Collect and maintain outcomes data by demographic variables and reviewing that information to improve service delivery. Reviewing satisfaction scores and consulting with youth and families, again being youth guide and family driven, to adapt and modify services so that they are culturally responsive. And then partnering with community stakeholders for cultural resources to disseminate information and to consult about the health needs of the community. And then finally, creating conflict and grief processes so that if there are concerns, that there are procedures and guidelines in place to address cultural issues that may arise. As you think about implementation of the National CLAS Standards within your behaviors, you also want to think about the CLAS standards from a local and state perspective as well. Kathy mentioned that I work with the Jacksonville System of Care Initiative, and so we facilitated a process of conducting cultural and linguistic competency assessments with 10 local child-serving behavioral health organizations. And as a result of just that assessment processes, we saw major changes in the way that agencies were providing services to children, youth, and families. For example, many of the agencies mandated required cultural and linguistic competency training for all staff. Many of the agencies prior to the organizational assessments did not have language access plans, but as a result of the assessment process, they established language access plans, and they actually began to collect data specific to linguistic differences. Also, they integrated cultural competency into their existing strategic plans. Many of the agencies had no information about demographics or, community engagement or, analyzing health outcomes specific to demographic differences. Many of the agencies did not have a plan in place for that, but as a result of the assessment process, cultural competency was integrated into those strategic plans. Another major step that we took in our community here in Jacksonville was including cultural competency in contract language. One of the major requests for funding proposals for our community included cultural competency as criteria for funding. And so that was a major step. And that was because we were actually at the table and we were emphasizing the importance of family-driven, youth-guided, and culturally responsive services. So cultural competency was actually part of the scoring for receiving funding to provide behavioral health services within a public school setting. That was the focus of that particular RFP. Currently, we are working with the Department of Children and Families at the state level and other key stakeholders in considering other strategies for statewide implementation, such as statewide CLC training, systematic collection of demographic data, and again, the inclusion of the CLAS standards in strategic plans for all agencies that are receiving state funding. I also wanted to mention a resource on the Think Cultural Health website that includes a compendium of states that have implemented the CLAS standards and the process that they went through in order to become a culturally responsive state. And so many of the categories on that website include policies, planning, and collaboration, dissemination, training, and significant achievements that many of the states have made in terms of addressing cultural and linguistic competency using the CLAS framework. So now we'd like to briefly share about an example of a system of care grantee, One Community Partnership 2, which we'll refer to as OCP2 in Broward County, Florida. Because of the increased diversity in Broward County, Florida, and data findings from OCP2's Disparities impact statement, it revealed a need for greater emphasis on cultural and linguistic competency. The data showed an increase in the number of individuals with limited English proficiency and greater racial and ethnic diversity. The profile also showed significant poverty levels and growing disparities in terms of school graduation rates. So OCPT established a cultural and linguistic competency committee that was very diverse, included family members, youth, and also providers, staying true to their core values of being family-driven, youth-guided, and culturally responsive. This committee and project team felt it was critical to begin a process of assessment and quality improvement. So they focused on CLAS Standards 2, 9, and 10, which address organizational governance, operationalization of CLAS standards and organizational policies, and the assessment of class-related activities. So OCP2 partnered with the National Technical Assistance Network for Children's Behavioral Health in order to analyze and assess each of the behavioral health provider organizations' CLC plans using the CLAS standards as a framework. The CLC competence team for the TA network worked with the Covian Consulting Company to design a tool and a process to assess providers' cultural and linguistic competency plans and their compliance with the CLAS standards. So the first step was to examine the CLC plans from 30 behavioral health contracted service providers. And after they examined the plans, they formulated a list of commonly missed components and other information that was not specified by the plans in accordance with the CLAS standards. Secondly, Covian used these results to create an assessment tool designed to serve as a guide for agencies to improve their CLC plans and better serve their populations of focus by operationalizing the CLAS standards. The third step was to evaluate the plans and implementation of the CLAS standards. Two separate researchers, often referred to as raters, examined each of the 30 CLC plans and determined compliance and omission rates for each of the CLAS standards. The next step in the process was to create a report that included a description of the results of their analysis. These results were reviewed with the providers, both from an aggregated perspective as well as individualized reports, and the results revealed that existing CLC plans were limited in their scope and had not been updated regularly. They also found that providers were not aware of the existence of the National CLAS Standards. So in the fifth step, the leadership of OCP2 began the process of providing feedback to providers about their individualized reports. In addition, they held a spring meeting where they spoke about the strengths and opportunities for improvement with their data. And then also they had some conversations with their managing entity to embed contract language to ensure ongoing quality improvement and updates to the CLC plans. The final step was the process of reviewing their results and implementing change as needed. A few agencies have requested additional technical assistance in addressing the needs identified by the assessment process. For example, 2 agencies requested assistance in developing a CLC plan that better operationalized the CLAS standards. And so the TA network has partnered with several of the organizations to assist in incorporating these changes and strengthening their CLC plans. Okay, I think we have an example of the CLC tool sheet that was used in the Broward County community. Okay. And that tool sheet will be available to all the users who are on the, all of the listeners on the call today. So we'll make sure that you receive that toolkit. The next slide gives an idea of the data that was gathered and how it was reported. We mentioned that there were 2 raters that reviewed the CLC plans, and the first table examines what CLAS standards were not mentioned in the provider CLC plans. So the raters provided their percentages, and then average of the two percentages were used for reporting. Okay. The next table reports the compliant rate. It shows what percentage of the 15 CLAS standards each agency included in their CLC plans. So there were 30 agencies, and so this outlines which CLAS standards were actually addressed in each of the CLC plans. And you can see that there's lots of variation here. So this is an important process because it improves the equity and it also reduces disparities. It improves access by helping providers and agencies to operationalize the CLAS standards and to actually put them into practice. For example, an agency that has a written language assistant policy that is operationalized increases access by providing translation services for those with limited English proficiency. So in the end, improved access means underserved populations can receive effective services. And when this happens, outcomes are improved and disparities are reduced. Okay, we have a few reflective questions here. We're going to open up the lines. And also, if you'd like to type your response, you are welcome to do that as well.
And as soon as the lines are open, Emily Cohen, who's the project director for the Broward County System of Care, OCP2, that works very closely with Tobian and Katrina. And Emily, I was just wondering if you'd like to share a little bit of the experience that you had and that the county had.
Sure, I'll be happy to share. Can you guys hear me okay?
Yes.
Okay. So basically, it was a community effort to try to understand where we were as a baseline in terms of implementing the CLAS standards. Having the grant just been around for a year and a half or so, we knew that through the planning and the implementation process, we had some work to do. So this was our way to get a good baseline, get a grasp about the provider's implementation of their CLAS Standards and then start learning from there how we can improve. So now we're in our first year of our implementation and expansion grant, and we've been able to start, we've educated the agencies, our contracted providers, to our managing entity on the CLAS Standards, so they are aware of the tools of the standards as a whole, because I think a lot of people didn't really know that these standards existed and there were guidelines and those kinds of things. So that was a really good process. We were able to talk about it during our contract negotiation meeting and start the conversation about where we want to go from here. So now the intention is, since we've already reviewed, we have the initial highlights of what needs to be addressed. Now we're going to accept some action plans in the next couple of months, and then in the next spring for our next contract negotiation meeting, we'll review the standards again, which hopefully now will have improvement, and we could compare year 1 and year 2 data so we could see how that's been implemented. So it's been well received, and a lot of people are thankful that we've been able to start the conversation and the education process.
Great. Thank you, Emery. Does anybody have any questions, since Emery's on the line, in terms of what Broward County did or how they managed to accomplish the, get their providers on board? I think that's sometimes that's the big question that people have.
Kathy, I was just going to add that in Jacksonville, part of the buy-in for us was really beginning with educating the leadership. So we facilitated trainings with leaders of behavioral health organizations first to make sure that they really understood what we meant by cultural linguistic competency, because it means a lot of different things to different people. And so our first step was to educate the leaders and to make sure that we were all using the same language and that they understood what the CLAS standards were. And so that was really helpful in terms of laying a foundation for the organizational assessment process.
Great, thank you. Is anybody else on the... Oh, I'm sorry, go ahead.
I was just going to read the first reflective question: how has your organization implemented CLAS standards? So we'd love to hear from other communities or organizations, whether it's a family organization or a behavioral health organization or a clinical setting, about how your organization has addressed the CLAS standards.
I know one of the suggestions that community had, this is Kathy, that was talking about crosswalking, looking at their strategic plan, their system of care strategic plan, and crosswalking it with the CLAS standards to see if within their strategic plan the CLAS standards were addressed. So they found it really helpful as a foundation or as a guide almost to looking at their strategic plan as well. We had, oh, go ahead.
I was just going to say that I'm reading some of the comments here. I do not work directly with any of the agencies. However, we have a problem with access to Spanish-speaking therapists, psychiatrists, and case managers. Has this been an issue for other communities in terms of accessing multilingual therapists, in-person interpreters? I know in Jacksonville we have established contracts with various interpretation service companies here in town, and so have not faced that barrier. And we have funding through our System of Care grant to address linguistic competency. But I'd be interested to hear how other communities address the need for linguistic services, in-person linguistic services, interpreters.
But I have a, can you hear me?
Yes.
I have a question about Florida, though. You're talking about interpreters, correct?
Yes.
See, being a clinician myself, having to work with an interpreter, the conversation and the therapy isn't fluid. And it's, obviously interrupted, and everything takes twice as long when you have an interpreter. So in my county, we would like to try to increase the number of bilingual therapists and psychiatrists that are out there, because interpreters just, to me, does not fix the problem. Has anybody had any luck with trying to find an incentive to try to get more, outpatient mental health clinics to hire more bilingual people, or programs to send people to school to become bilingual?
I think this, ties closely to the CLAS standard related to workforce development. That second category, the importance of recruitment and training of the workforce. So I know that here in Jacksonville we formed some partnerships with professional organizations, as well as partnerships with academic institutions in identifying students that are bilingual, and some of those students actually become part of internships with agencies, and then are able to become gainfully employed after their internship. So there is a need, and so I know that we're doing some partnering with our academic institutions, University of North Florida, Jacksonville University, and so forth, to help with ensuring a diverse workforce. Are there other comments? The second question is, what were some of your organization's successes and barriers, and what were some of the solutions to some of those barriers that you experienced in terms of addressing cultural competency or the implementation of the CLAS standards? Comments? I see a response from Denise Baker. She says that they review their cultural competency plan on a quarterly basis. As we grow and develop additional supports and services across our state, we're beginning to increase the utilization of technology to reach individuals and communities in remote areas. I would welcome any thoughts or ideas or experiences in taking steps to ensure that these interactions via technology platforms or technological platforms are culturally sound. So I know that telemedicine is becoming more popular, particularly with the shortage of behavioral health providers in many communities, and also access issues in rural communities. And so many communities are using a collaborative care model of training primary care professionals in how to assess for depression, suicide, and other mental health disorders to close that gap in terms of accessing services. Kathy, do you have any experiences with telemedicine and ways of addressing?
Not telemedicine, but I was just thinking of our own experience on this particular call as well. I mean, in terms of for the deaf and hard of hearing, and being able to provide those kinds of services, and looking at that, and I know that Colin had said earlier today that, that all of these presentations, for example, are put on YouTube, which has that capacity. So I think that, it's something that we're all really trying to look at to see how we can make sure that all these kinds of presentations and things like that and using technology are really culturally sound and responsive. So, I think YouTube is kind of is pretty advanced in terms of being able to provide the kinds of things that we're hoping to be able to provide in some of these calls.
We also have a response from Ms. Ward White. Says Colorado has been working with the implementation of the CLAS standards. They've created an extensive interpreters and translation assistance resource bank, but cost has been presented as a barrier. Are there any suggestions from other communities in terms of ways of addressing the cost issue in terms of securing interpreters and translation services?
Yeah, we've noticed more and more budgets for plans, including, even National Technical Assistance Center budgets that have a fairly large budget to, that includes translation and interpreters. And it's almost a set aside, these budgets, because you may or may not end up using them at the end of the year. So you're going to have 3 or 4 meetings. You've set aside money to provide, to do the translations, to provide an interpreter, to do translation materials. You may or may not need that interpreter. And by the end of the year, you have some money left over. But I think that what we're seeing a lot of these set asides for that particular, to address that particular thing in cultural competence. It's tough though.
I'm sure you have plenty to do. Right? You look tired. Go home. Eat lunch. I want to drive now.
Also in Jacksonville, we've been working very closely with ethnic community-based organizations through our Department of Children and Families. These are refugee immigrant groups, individuals who need employment, and so our DCF office has sent individuals for training. And so we're able to work with those ethnic community-based organizations, sometimes at a much lower rate than working with contracted companies. So that's an alternative in terms of cost savings. For our final question is, what are 2 things that you will implement with your organization as a result of this call? So what are some things that you've gained from the call today that may be helpful in implementing the CLAS standards within your organization or agency? We'd love to hear your feedback.
Because one of the things, as we said, that we can do and that Broward County has been really generous in doing is sharing their reports with us and, sharing the instruments that they use. And so, we could provide that as well if folks would like to see that.
I'd also like to mention that we do have some resources as a part of this presentation. Our CLC library through the University of South Florida, also the National Standards for Cultural Linguistic Appropriate Services, the state compendium that we mentioned through the Teen Cultural Health website, and some additional references with tools and resources as well.
And I think somebody had asked a question, Rebecca had asked a question earlier as a prevention technical assistance and training consultant. She works with providers and not directly with youth and families. Does anyone have any suggestions for incorporating CLAS into consulting services? For me, I think that in terms of organizations, you can use CLAS because it really does look at who your board of directors is. It looks at, the governance piece. It looks at how you're doing it. So I think sometimes you can do those crosswalks with organizations, and it's something that, we're looking at actually at the center as well. And I think that, and Rebecca, I can share with you some of the materials that have used at USF as an organization that we're trying to crosswalk with CLAS as well. So. I think we have your contact information, so I'll reach out to you. Any other comments or people that are using the CLAS standards now? As a foundation for some of the work that they're doing? Well, what we'll do is as we said, this will be all the materials that we talked about, and the materials that Emory and the folks in Broward County did will be made available to you. So you'll have those materials as examples, the resources. Think Cultural Health, as Selena said, has a number of resources out there. We also have this idea of using the CLAS standards within a system of care at every level within the system of care. So
that you transfer to the other one.
We're having a little bit of technical sound difficulty, I think, so we apologize for that. And what we can do also is, you asked the question about Spanish-speaking therapists. What we can do is we can try to pull together some resources that other communities are doing. We can put out a email to folks and just find out if there are any strategies that people are using, to address the issue that you brought up.
That would be helpful because we're not directly linked with the outpatient mental health clinics, but it's
right.
Who we were obviously refer our people that we encounter to our crisis response system. And for families that are Spanish speaking, there's really not much of an option.
Right, right.
We partially pay for a psychiatrist at one of the larger clinics, a Spanish-speaking psychiatrist, but he's always busy, and they also only have one therapist, and she's always busy. So we've tried to do as much as we can with funding, but yeah, that's a big need in our county. So I would really appreciate that.
Yep, well, we'll definitely do that. It's 2 o'clock, and this is just an hour call to give you some information and hear from some of the people that are doing things. Thank you again, Broward County. Thank you all for being on the call, and you'll be receiving an email to additional resources that we have for this particular topic, and those of you that had asked questions, we'll make sure and send you additional information as well. So Selena, thank you very much for your presentation. Broward County, thank you very much, and all of you have a good rest of your day. Thank you.
Thank you.